This week on the BackTable podcast.
There are patients, not all of them. Some of them it could be something as simple as, hey, they never actually had a full hematologic workup, and it turns out they've got this other disorder that needs treated to prevent the long-term complications of rethrombosis. And then there's another group of patients that, they'll be like, hey, this patient needs to be recanned. And they've been told, no. And like, we do it. And in fact, we just saw somebody from out of state he saw 5 or 6 people, I think he was from the South, and just was looking for like a place to go. That we ended up recanning him, and he got his hematologic workup, and like, he's as happy as can be. And it's mainly because of that. It's just like a place to go.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. Today, we're going to be discussing treatment options and management strategies for portal vein thrombosis. If you're interested in this topic, we've covered this a bunch in the BackTable podcast. So there was episode 541 recently, acute portal vein thrombosis with Ben May at Cornell. Riyadh Salem has been on the podcast with us for episode 223 for complex portal vein recanalization techniques. And then we also had Tips University around episode 126, where towards the later episodes, we talk about chronically occluded portal veins, how to get into those, and how to lay down the tips. Today, we have Dr. Vijay Ramalingam, Vascular and Interventional Radiologist from Beth Israel Deaconess Medical Center, Boston, Mass. He's going to be discussing his practice, his clinic's approach to treating these patients with portal vein thrombosis. When looking at this topic, I wanted Vijay to come on because I think what he and his colleagues are doing at Beth Israel with a multidisciplinary approach will have some interesting insights into treating these complex patients. Vijay, welcome to the show.
Thanks for having me.
All right. Icebreaker, will you just tell us a little bit about your training and about your practice over in Massachusetts?
Yeah, so I did my medical school and residency at Boston University. And then after Boston University, I did my fellowship training at Emory University in Atlanta. And I've had a circuitous route back to Boston. I worked in Boston for several years, and then my wife and I moved down south and were working in Louisiana at the Ochsner Clinic for a number of years. And then in 2020, we came back to the Northeast, and I've been practicing at Beth Israel Deaconess since that time.
Was it a COVID move? Was it like a midlife COVID prompted crisis that you had to get back to the Northeast?
It was certainly a little bit of a COVID move. We loved living in New Orleans, loved my colleagues at Ochsner. I know Tyler and Juan have been on here before, and they do great work. But my wife's family is from the area, and so we, at that time, had decided it was probably the right time in life to kind of pivot back here and see where we go from there.
And so been at Beth Israel, so that was the first job you took there, and you've been on staff since?
Yep.
All right. Actually, you know what I want to know? So you were coming into your career like kind of mid-career practice. So whenever you took the job, was there like an understanding of what you were going to lead the charge on? Or they're just saying, hey, come in and carve out your practice? Like, I'm interested to see how that went for you.
Yeah, that's a great question because it's also something that I feel like I've done now twice. Because Ochsner was my second job after fellowship. And as you know, they were doing a ton of great liver work already. And I was still technically early career. I was under my 5-year mark. But you also, you want to go in and you want to contribute, but you also don't want to be the guy that goes in and is, hey, I'm going to show you how everything's done.
Sure.
And so when I went there, I think it was more, there was just so much work and so much volume, and they'd already built such a great practice that we navigated that pretty well. And I kind of focused much of my practice around tumor ablation and this portal work that I had really been building towards since my fellowship days in Atlanta. And when I landed at BI a couple of years later, we had a little more structured discussion around it. When I interviewed for the job here and I talked to the division director here about, kind of where I would fit, how can I fit, already what I thought was a great practice, and making sure I had something that was going to be professionally satisfying for me and interesting for me, but also make sure there was space and that it wasn't going to be taking something from somebody else or, hey, like all of a sudden it was going to come in and create all these conflicts. And so I had a pretty good idea when I came here of what they were looking for and what I was looking for in the next phase of my career.
That's great. So I want to segue into talking about the practice I don't want to put it all on you, say it's the practice that you created, but talk about your practice and specifically the clinic that you guys, the multidisciplinary clinic that we had talked a little bit offline about that you had. And I just kind of wanted you to, one, describe it. Actually, sorry, that's wrong. Let's first just lay down the groundwork of like portal vein thrombosis. What is it? Who gets it? And then why it's important to have like a clinic or a way to manage these patients.
Yeah. So we'll start with that. So I think portal vein thrombosis, or as we kind of call the clinic, the Splanchnic venous thrombosis clinic, really encompasses 4 or 5 veins, right? You're talking about the portal vein, you're talking about its tributaries, you're talking about, we include the hepatic venous system in the categorization for Splanchnic venous thrombosis, as well as the splenic, the SMV, and its tributaries. In terms of who gets it, what I say is everybody actually gets it. And so I think we have a tendency to lump everybody together of like anybody who gets it is probably somebody who is with cirrhosis for a variety of reasons. But the reality is certainly patients with cirrhosis are at higher risk amongst really any of our populations of getting portal vein thrombosis, whether it's occlusive or non-occlusive thrombosis. But young patients get portal vein thrombosis that do not have cirrhosis, as well as adults that do not have cirrhosis. And oftentimes, actually, those patients without cirrhosis end up having the more complex challenges on how you manage it, how do you manage anxiety, patient anxiety, and how do you not manage them in the immediate, because many of them will actually do quite well immediately. But, if somebody gets diagnosed at the age of 19 or 20, you also need to look, what do you tell them? What does your next 50-year outlook look like? And so, really, it's a broad scope. So by percentages, cirrhotic patients are going to get it more often than non-cirrhotic patients without cirrhosis. But really, anybody is at risk here.
Okay. So that brings me then to bringing up the clinic. How about some historical perspective? How long have you guys had the clinic?
Yeah, so the Splanchnic venous thrombosis clinic. For historical perspective, when I got here in 2020, and I think you already alluded to this is certainly not a me project, and I would never take the credit for it. Actually, I would say Dr. Michael Curry, who is the head of transplant hepatology here, and my current section chief, Dr. Manib Ahmed, had this idea percolating for a few years beforehand. And what they were running was a conference that was about every 2 to 4 weeks. I may be misquoting that exactly, but they would try to get together once a week and review these patients. And over time, that kind of built into a little bit of a referral source. So at least our GI colleagues knew there's a place to go to discuss these patients. But, there was always this vision of, hey, we want to actually start a real multidisciplinary clinic, not a 1-hour kind of drive-by conference that is hard for everybody to get to. It's hard to resource that way because people are just busy. And as I'm sure we'll get into a little bit, these patients are also quite complex. And so that kind of evolved to the next evolution of it, where in 2020, where we had gotten hospital approval for starting this clinic, we had gotten the clinic space. So we now have an actual clinic space that is 1 afternoon a week. And we, started working towards how we wanted to set this up. Myself and at that time, the other co-director of the clinic, Dr. Lauren Yang, ran a conference that was the lead up to it. It was a virtual conference once a week for an hour. And it was myself and Lauren as the co-directors, and then now Dr. Jonathan Berry, who's a hematologist. The three of us would review these cases, and then about fast forward a year, we got into the physical clinic space.
Dr. Yang, what's her specialty?
She's a transplant hepatologist.
Okay, got it.
So fast forward that, I think it's about a year and a half later, we get the actual physical clinic space. At this time, we've hired a nurse coordinator as well as a clinic coordinator. And so now we're kind of off and running. We start advertising it a little bit internally. Like we let the GI doctors know, we let the transplant surgeons know, we let the surgeons know that, hey, there's this clinic we're trying to do. We're trying to get this off the ground. For anybody that presents with splanchnic venous thrombosis, you can add it to the clinic list and we're happy to discuss them. And we run the clinic very similarly today. So the first hour of clinic is actually just a conference where anybody can add a patient on within reason, meaning if they if they jump on at 11:59 and say, hey, I have this thing for 12 o'clock, then we're like, well, we might need to push this for next week. But people can just add on whatever cases they need to add on to discuss, whether it's inpatient, outpatient, somebody they saw within the network. And that runs for the first hour. And we discuss conference patients that different providers may have questions on who aren't necessarily being seen in the clinic. Mm-hmm. We make a rough recommendation. Most of the time it's, hey, this is sufficiently complex that we think it's worth them being seen by us. And our clinic coordinator works with the patient and the doctor or provider to actually get them scheduled, get their imaging done, and get them set up in the clinic space. Then the second part of the clinic after that first hour of conference discussion is an actual multidisciplinary clinic where we usually have about 5 to 8 slots where we see new patients and follow-up patients. And in that scenario, the patients that are all discussed in the conference, but then we each individually see them. So they're seen by a hematologist, they're seen by a hepatologist, which is either Lauren or Michael, and then they're seen by an interventional radiologist, which is either myself or Mandeep, who are the two that staff the clinic right now.
Okay, very nice. And when you're doing the conference part of it, the patients who are getting presented, there are some that end up going to the physical clinical space, and there's some that that do not make the cut because of the complexity is relatively low or the case is relatively straightforward. Like, I'm interested to know what happens to those patients who don't make it in.
Yeah, so it's interesting. This is also an ongoing discussion even within the clinic because it's not always straightforward. And I think one of the other things about PVT is you may have somebody sitting fine for 10 years before they present with all these problems. Now, there are questions which are still a little unanswered, is could you have done anything about it anyways? But the other end of it is, should that patient be seen every year in the PVT clinic and just get them taken in right away so that at least they've got a touch point? And so what usually ends up happening, if you look at where our clinic is, and we're trying to publish on this right now as well, that's out under review, most of the patients actually convert from conference to clinic.
Okay.
Almost all of them, not all of them. The ones that don't end up converting are actually the patients that are either already seen by a hematologist or are already seen by a hepatologist. And oftentimes what they're really looking for is a very specific question, and they're so knowledgeable in this space already that it's not good for the patient to have to bring them into downtown Boston for another clinic visit when it may not be necessary. And they may only be asking hey, they'll tell you everything. I've already done the hematologic workup. I've already been following this patient for 1 year. They're starting to get vague abdominal pain. We have this imaging. It shows stable thrombosis. Is there something the interventional radiologist can do? Yes or no? And that patient, if the answer is no, probably doesn't necessarily need to be seen by us. But now our colleagues, maybe in primary care or family medicine, who are so overwhelmed with so many disease pathologies, they may just show a conference patient and say hey, this patient showed up in my clinic yesterday, has this random CT that has thrombosis everywhere. I have no idea what to do with this. And then we just say, this patient needs to get seen by us. Just get them into the clinic.
Got it. Okay, so say I'm patient A, I end up in the clinic. You can create whatever clinical scenario makes the most sense. I'm just interested, what then does it look like from the patient perspective? Am I seeing all 3 providers that same day? And then afterwards, there's this comprehensive plan? Yeah, shoot.
Yeah, so there's a couple things we try to do. And so the first step for that patient is we call and schedule them. Our clinic coordinator, Sam, and our clinic nurse, Emily, are a really incredible resource because they tie up all these loose strings that like just wouldn't be able to work without them. We all know how this goes.
Sure.
And so what we try to do is once we know they need to get there, in the multidisciplinary conference, we discuss all the clinic patients for that day. And we kind of have an idea of what is our preliminary plan going in.
Okay.
Then for the patient, once they get roomed in the clinic and they get their vitals and they get set up, what we try to organize is all patients that need imaging get it done the same day so that they're not being, drug in and out of town for 4 different visits, for example. So we get an ultrasound and a CT on all of them. If they need new imaging because they're not up to date, we try to get it coordinated the same day. So they go to radiology, they get their imaging done, then they come to the clinic, they get checked in, they get roomed, and they see each of us individually. Now, let's just say a clinical scenario out there. I think somebody without cirrhosis is a good example here, that if that patient is showing up for the first time, they have this new diagnosis, they don't know what's going on, they'll need a little bit of workup from hematology and hepatology, particularly hematology. So Jonathan, who's the hematologist, Dr. Barry, he'll go see the patient, kind of discuss everything, discuss the natural history, and he'll order like a battery of thrombosis tests for their hypercoagulable workup and, try to take a pretty detailed history of, is there anything in childhood that could have caused this? Is there, any history that may have just kind of been a one-off, like that you may not be thinking about, hey, it turns out this kid had a splenectomy at the age 10 because of some random hematologic issue or something. And he gets all of that stuff done. Similarly, Lauren sees the patient, talks about what needs to be done on the liver management end and liver workup end. And then after that, in no particular order, I would see the patient and talk about what are the options for vascular and interventional management. You're like, do we need to do it? Do we not need to do it? What are the potential success if we do versus if we don't? And then, if we decide not to do something, is it an option later down the road? And we get into that discussion. That happens during their visit individually with us. And then after that, for whatever laboratory evaluations they need to get done, which many of these patients do need to get done, we try to get all the labs done during the visit. So the clinic space has a phlebotomist. We draw the labs, they get sent. The patient leaves with a plan and their follow-up plan, as well as their follow-up imaging plan. We try to get that all scheduled for them so that, everything is, again, getting done in one visit. Because if you think about it, particularly in the way things kind of work and how busy people are, if you're able to consolidate these visits down from 4 or 5 visits to 1, that's a huge service for the patient. And one of the things that we talk about is I've got examples of patients that were seen by 30 to 40 different visits over the course of a year, just trying to get to the right place. And they don't even care about the management at that point. They get to the clinic and they're like so thankful. They're like, thank you for not making me drive into town like 40 times. Just getting everything done and that's what they want.
Okay. So I wanted to pause on a couple of things. So as far as the imaging, you mentioned ultrasound, abdominal ultrasound, and then CT. Are there any specifics, like if you had to help IRs out there who are maybe getting this practice off the ground, multi-phase, like any specifics on the ultrasound, like anything extra that you're doing other than a Doppler? And then from the CT side of things, is there any specific protocols that you guys are using that you found helpful? I'm assuming you probably played a role in this part.
Yeah, so we get a standard Doppler ultrasound on everybody, and a lot of that is based off of screening guidelines that still recommend a Doppler ultrasound. On that end, I would say I'm not adding much until post-procedure.
Okay.
Post-procedure, I'm not actually sure. I think we all know it has, great value in documenting TIPS patency and potentially evaluating velocities. However, the part of that is less clear is what is the real value of the ultrasound evaluation after you recant a patient that may have had extensive thrombosis and their flows are just going to be different and they need to be followed differently. but we still do it. We get the ultrasound, we document the TIPS patency. Particularly for young patients, this also serves as their HCC screening if they require that. Now, on the CT end of it, if that's the route we're going to go, for anybody getting started in this practice, I always recommend, particularly if you're going to intervene, get a triple phase CT. It makes your life easier. Now, most of the time, particularly early on, if these patients are going through the emergency room where they're like showing up with abdominal pain and then you get called, they are going to get that CT. But a few times a year, there'll be a scenario where somebody was intervened on and you'll be like, well, they didn't have cross-sectional imaging. And it happens, usually at an outside hospital where they maybe didn't have the 24/7 staffing for something like that or whatever, and it was considered an emergency scenario, and then they end up bouncing to us at some point. But I like a triple phase CT. I do get an arterial phase. The reason I like the arterial phase is if they have anatomical variation, it does help in your TIPS planning so that you know where you could potentially expect a problem or potentially expect that, hey, maybe if I actually do a right-to-right TIPS, I might, in the process of getting into this like diminutive chronically thrombosed thing, there's actually an artery there just to be aware of. So I do get an arterial phase. I get a standard 70-second portal venous phase. I recommend getting the scan from the lung bases all the way through the pelvis for a couple reasons. Number one, it delineates your hepatic venous anatomy, which helps you for your treatment planning. Certainly, it gives you an idea of your portal venous anatomy. And if you're going to end up using either transplantic or a transhepatic or a transmesenteric approach, you have an idea of the vascular lay of the land, I should say, going into it. And then I also like to get down to the pelvis, and that's where it gets down to, let's say, okay, you've done everything, you've done a TIPS, but maybe you need to make some augmentations to flow or make some shunt adjustments so that you can really maximize the flow through the TIPS. You know what the entirety of the anatomy is of any pelvic venous collaterals that have developed or any like dominant IMV or gonadal branches that have developed. And it just helps you treatment plan around that.
So one of the other things you mentioned that I wanted to bring up is that when, patient A is in the clinic, they'll get seen by transplant hepatology, hemonc, the hemonc may come in, do a detailed history, and then run the battery of lab work. But the decision whether or not you're going to recommend treatment, like from the IR perspective, that's kind of already been made. Or maybe I'm mixing it up.
No, in some senses, yeah, because we talked about it in conference, right? So
Sure.
We've had this discussion in conference about patient X, like, hey, this is somebody that may benefit from this. And so there are patients where I kind of look at it and you get a lay of the land just in that discussion during the conference hour. And you say, just hearing the story, this patient is probably not the ideal candidate to revascularize. There's very little benefit for potentially taking on some risk. But you see the patient and that has changed. And we have those patients where we get in there and they're like, well, you know what? It actually is hurting every single time I'm eating. Or,
yep.
Hey, people have told me this thrombosis is no big deal, but I've lost 30 pounds in the last year and a half. I am having diarrhea every time I eat. But people just keep blowing this off. And so the clinical exam in that scenario does help us make some decisions. But to your point, it is very much a collegial kind of, the three of us discuss it. We usually have a good idea of where we're heading going into it, but about 10 to 20% of the time, I'd say you'll see like a change. And we've had some patients that have even been so severe that they've ended up going to the ED straight from the clinic for not necessarily directly related to thrombosis, but complications of.
I guess like the line of questioning that I was going to pursue was that in some ways, or maybe for some patients, not all, but you're almost like the treatment, the IR treatment could run in parallel to the hemonc workup of like where this started. It's almost, okay, we're here from an IR perspective and this is what we have to do moving forward, but maybe necessarily like was a JAK2 mutation versus some random mutation, like you're prothrombotic and this is just like your lot in life. And now that this is what we have to do moving forward.
Yeah. So I think if I understand what you're asking, yes, these things do move in parallel. And in fact, our own experience has suggested, and I'd say it's also panning out in the literature, and I think we'll see more of this. It's easier to deal with somebody in the acute phase. and I don't know how much of your practice right now is centering on this back home, but so like if somebody comes in or is discussed by us in the conference setting, for example, or even in the clinic that has recent PVT, I think is the newest terminology from AASLD.
Okay.
They don't have a history of cirrhosis. There's no reason to believe they have cirrhosis based off of imaging, and they have recent PVT. They've got symptoms. Jonathan or the hematologist will run the battery of tests, and I would probably also recommend we treat. This is where some of our most interesting discussions kind of stand right now, is who needs to be treated and who does not, particularly for these acute patients with non-cirrhotic PVT, where they don't have cirrhosis, but they've got acute PVT and they have symptoms. And this is where, if we kind of come to consensus that we need to do something, we advocate that it goes in parallel. And the reason is it's just much easier to work with these patients when the clot is fresh. The patency rates are better. It's easier to treat them. And then you're also not fighting against collaterals that have formed over the next, 3, 6, 8 months.
So I guess that then leads me to the next set of questions. So trying to get in a little bit into the algorithm that you guys work with framing patients, for the audience is a lot of endovascular community. So from the IR perspective, but do you guys have a way of classifying these patients that helps, that may help the audience members, like a way to think of, okay, acute versus chronic, cirrhotic versus non-cirrhotic, that helps then like push them into one pathway or the other?
For treatment, you mean?
Yeah, for treatment.
Yeah, so acute cirrhotics that show up, or I should say, we're supposedly moving away from, my hepatology partners get mad at me when I say cirrhotic, but we're supposed to be saying with cirrhosis, but I still say it. Acute patients with cirrhosis that present with acute or recent thrombosis, in general, we push towards intervention. And, there is shared decision-making, and we all know that there's shades of gray here, but it's a number of reasons. Number one, because I'm very fortunate. I've got great colleagues in hepatology and hematology, and so we do a comprehensive workup on the patient. They're getting evaluated, and we're going to make sure they're an adequate or an appropriate candidate and they can tolerate any procedure. We're also thinking long term. Patients with cirrhosis and who go on to develop PVT, which many of them do, particularly if it's occlusive PVT and it starts extending into the tributaries, there are many downstream effects that need to be considered. Number one, what's going to be the effect on transplantation in 5 years? So maybe their MELD is low and they're doing great and they just happen to have cirrhosis and they happen to have PVT. They still may need a transplant 5, 8, 10 years down the road. And a patent portal venous system is going to be what they need. And that's how they're going to do the best. The other piece of it, patients with portal vein thrombosis who have cirrhosis and go on to develop variceal bleeding do worse than patients without portal vein thrombosis and cirrhosis who go on to develop variceal bleeding. And so it also becomes an issue of, it's actually just harder to medically manage these guys with beta blockers and anticoagulants. And so we tend to push for the cirrhosis patients with acute PVT, we try to treat. Now, patients with cirrhosis who have chronic PVT that is kind of long-standing, that tends to be more of a case-by-case decision. If they're asymptomatic, we tend to leave them alone unless they're being considered for transplant. If they're being considered for transplant, they get presented both in our conference as well as the transplant liver conference. We would revascularize those patients. I think, many people in the audience are certainly familiar with Riyadh's paper from a few years ago that really kind of threw this on the map, that these patients are able to get an end-to-end anastomosis after transplant if, us in the IR community are able to revascularize them, open the portal vein, you drop the tips for outflow, and in the surgical side, it's much easier for our colleagues in transplant surgery. But transplant is really where that patient group falls, or if they're having symptoms. Now, we have had patients that have chronic portal vein thrombosis who are doing fine, no indication for transplant, but then they show up to the emergency room and they've either got bleeding or, they've had months of melena or whatever the case may be. Those patients we would revascularize. Now, on the without cirrhosis end of it, similar algorithm for us. We try to, if indicated, the easiest ones are actually the symptomatic patients. If
Sure.
it's symptomatic with acute or a recent portal vein thrombosis and they don't have cirrhosis, that's almost a slam dunk for us that, we're going to be aggressive and we're going to do an early intervention, even if the symptoms are mild. And that's based off of our own experience here that, the patency rates are much, much higher when you intervene in that group. If they're without cirrhosis, without symptoms, and acute, then we really will do the multi-specialty visit like we normally do. And imaging helps us drive that a little bit because there are things based off of the literature. And that's if they've got a occlusive thrombus in the portal vein and the SMV, and maybe they're not symptomatic, we also know that the response to anticoagulation is going to be much poorer than if it's, hey, I have a little bit of non-occlusive thrombus in the right portal vein, and I just happened to find it because I was getting scanned for something else. So in that case, it's more shared decision-making, but if it's occlusive thrombus, if it's involving the main portal vein, the SMB, we would probably advocate like, hey, this is a good time to intervene to maximize the chance that you're going to get long-term patency. Now, the flip side of that is your patients without cirrhosis who have chronic PVT, and that's where it gets really, really challenging. And for a number of reasons. Number one, based off of what we know so far, patients with chronic non-cirrhotic portal vein thrombosis that get endovascular interventions, whether it be TIPS, which tends to be what we favor here in the United States, but there are centers that also advocate that they don't need a TIPS. Those patients, the patency is lower. And so you're taking on this very challenging intervention, but the patency rates are going to be substantially lower. And so there's that question. B, there's like a little bit of it, is the juice worth the squeeze? And if they're not having symptoms, but they've got chronic non-cirrhotic PVT, you're making some guesses of you're trying to kind of say, well, hey, we think this cholangiopathy is going to cause you a problem in 20 years, whereas we may not actually know that. And so there's a lot of question marks there. And so for that patient population, it's a case-by-case discussion. If they're having pain or if they're kind of saying hey, I'm starting to develop bloating symptoms or I'm starting to develop a little bit of fluid, then I would say we intervene. Stone cold asymptomatic chronic PVT without cirrhosis, more often than not, I would say we tend to say, let's do long-term follow-up in the clinic. We're available. I explain the options for them and say, with a little bit of shared decision-making, we may be better off. Let's let the hematologist and the hepatologist manage this until it's time for us to do something.
So I have one specific follow-up, just to what you recently said, then a ton of other ones. So one, if you have someone who is kind of at face saying, I'm asymptomatic, but then what are some targeted questions that you may pepper a patient with to say, really uncover if they're truly asymptomatic? Those specific questions where they're oh, actually, yeah, I do have diarrhea every single time I eat, or, the bloating question.
Yeah. So the first thing I do is ask Lauren to take the history because as we all know, our colleagues in medicine tend to be a little better at this than us.
Sure.
Where I really try to pin down patients, particularly in this vague crowd that you so nicely brought up, I actually try to pin them down on reproducibility. And so I'll ask them a whole host of questions around, they may tell me hey, I'm perfectly fine. I'm walking 2 miles every day. I'm walking up and down the stairs. I'm able to get coffee. I'm able to eat everything and this and that and everything else. And then I'll take it to the next level of stuff that's not necessarily difficult. It makes them think about it a little more. And you just start asking the questions of okay, well, when you walk this 2 miles, do you ever just have vague abdominal pain? And then every now and then somebody will be well, yeah, I do at the end, but I just figure I've been walking 2 miles. I'm okay, well, is it every time you do it? And we'll have a patient be well, yeah, it's every time it's very vague. It's at the end of my walk because I'm tired, but it hurts, literally in my right lower quadrant or my right upper quadrant. And then after 10 minutes, it goes away. And then, and then the next day, and I've gotten used to this over the last 2 years. So stuff like that, or particularly patients that show up with inflammatory bowel diseases. And or on the Crohn's spectrum, they'll say like, well, hey, I'm used to having diarrhea and bloating. So like, there's no issue with the thrombosis. I don't know what you're talking about. And then you have to kind of take it like, well, okay, I understand that. So last year you told me you were having, bouts of loose stools 3 times a day. And now you're telling me it's 5 times a day. Is your Crohn's doctor expecting this? Has there been a change in medication? And sometimes the answer is, well, yeah, we made all these changes. And, I'm fine at 5 times a day. I've lost 10 pounds, but I'm okay. And what you find is when you start actually asking for consistency is when the story starts to come off of the scripted narrative. I think that answers your question. It's like a little bit of a long-winded route.
No, that's perfect. That's perfect. It's exactly what I was looking for. The other thing that I wanted to drill down on is I find like when talking to people and then also like when reading about it, it's like, okay, let's separate things into acute and chronic PVT. That's a nice branch point. But in practice, it's sometimes much muddier picture. And so I was wondering if you could give the audience some tips about how you tease those two, like between recent portal vein thrombosis and something that's chronic.
The 2 areas that I would say get really, really muddy for interventional radiologists, because of how we practice and because of how busy people are these days across the board, are recent versus chronic and cirrhosis versus without cirrhosis. And so for recent versus chronic, we follow AASLD here, which recent is supposed to be under 6 months. They've advocated moving to this terminology essentially because of symptoms. And the argument is that acute actually has more to do with the symptoms, and recent is like a very definitive timeline that we can put on it. They put a tagline on there that if there's cavernous changes, you can kind of start to call that and get it into this chronic subcategory. And then after 6 months, chronic. Now, to your point, if somebody's showing up to the hospital or to the clinic or to wherever for the first time, and that's the first set of imaging you get, unless it's a stone cold acute thrombosis or recent thrombosis on a CT scan with a distended lumen, they're presenting with abdominal pain, it can be really challenging to figure that out of, is it this or is it that? But for the most part, we try to categorize that way. We use our radiologists to help us with this. And once we hit that 6-month point, we categorize as chronic. And then the other thing is acute on chronic is a thing because many of these patients rethrombose. There's a high rethrombosis rate in this population, both in patients with cirrhosis and without cirrhosis. Now, on the cirrhosis versus no cirrhosis end of it, this is where having a good liver doctor is awesome because, yes, there's all these imaging findings, but one of the things that our group has been really good at is anybody that's presenting to us, whether it's in the conference or in the clinic, we recommend a fiber scan. And for the most part, that it ends the question. It's easy to get, it's cheap, it's easy for people to interpret them, and then you have an idea, and very few patients need to go on to get a biopsy. So that's how we do it, and it's worked well for us.
Okay. So you had actually done like a fantastic job in like talking about like maybe the IR treatment algorithm, like with talking about these patients. I wanted to flip that and say, which patients, when you're also going through that similar algorithm, are going to tend to do well with AC alone or anticoagulation alone?
I think that's one of the hardest questions to answer in this space right now for a couple reasons. And I will answer your question. I know I'm giving myself the cop-out first. And one of them is nobody has really standardized this well in terms of what do we consider either a response to anticoagulation or a failure of anticoagulation. Now, some of the European groups and the Valdig group have done some fantastic jobs kind of categorizing what's out there and making some proposals on how future work in this space should be done to actually report these outcomes. But the way we work in the group, and this will kind of get around the response question. Technically, if they get put on anticoagulation, let's just say somebody comes in and they say, hey, this patient has PVT. We don't think they're a good candidate for an intervention. Let's trial them on AC for 6 months or 3 months and see how they do. Technically, response to anticoagulation means that the clot has not progressed and their symptoms have gone.
Okay.
Now, the flip side of that, and this is a little subjective, and I would admit that the evidence is still growing here. So this is some personal experience. I think anybody that works in any of the veins in interventional radiology, like there are very few areas in the body where we would say, well, hey, it looks the same as it did 3 months ago, and they're doing okay. So this is a great treatment outcome. You know what I mean? And so like and what I'm getting at is, for us, the way we evaluate in our group treatment outcome is, what is our intent for treatment? And for the most part, our intent for treatment is we want patent vasculature across the board. And so when we report, as you know, when we published on patients without cirrhosis and acute PVT, we reported SMV, splenic, and portal vein and TIPS patency. And to me, that's kind of a true estimate of kind of what you've done or what you haven't done, or where there's room to improve or where there's a room to study in the future. And for anticoagulation, it gets a little more dicey, because what they're really looking for is, did the symptoms improve and did we stop the progression of clot? Now, ideally, and Jonathan will tell you this himself, ideally, what you're looking for is, yes, it's completely regressed and it's gone, but that's not necessarily their benchmark.
Okay. So then going back to the question that I'd kind of posed to you, at least in your group's experience, if you could take that same like classification, which patients tend to respond well with anticoagulation?
So if somebody comes in, let's start with especially non-cirrhotics. I think those are some of our more interesting things right now.
Okay.
Somebody comes in without cirrhosis who has occlusive thrombus of the right, left, main portal vein, and SMV. The betting money is that patient is going to fall into the 70% that fail anticoagulation. I think that pans out in the literature, and that also my hematologist would tell you that. Our subjective experience would tell you that. That patient is like a slam dunk of like, hey, we should do something. We know we can do something for them, and we know we can do it safely.
Okay.
Now, you take a different patient and you bring them in, and they've got maybe occlusive thrombus, but it's only involving the left portal vein, or it's like a short segment occlusive thrombus of the IMV or a branch vessel of the SMV. That patient, trial them on AC before putting him through a procedure.
Right. What about partial portal vein thrombosis that may or may not extend into tributaries in the setting of the non-cirrhotic? I hate to keep throwing out every single scenario.
No, and these are the scenarios that come up. I would agree with that. So I would first say, to keep it somewhat evidence-based, we would still try to categorize based off of either ASLD or Bovino. And so that means getting into the percent of the lumen involved.
Okay.
So if it's like you look at the CT scan and by definition, they've got non-occlusive thrombus, but maybe only 15% of the lumen is involved, it's 50% of, it's a short segment of the vessel, I would actually say that patient is probably a pretty good candidate for anticoagulation. My guess is, not to speak for anybody, my group would agree. We would say, like, this is the way to go for this patient. Immediately start them on it. Let's get them a short-term scan and see how they do. Now, we've been burned on that before, but for the most part, this is the route to go, and I think most would agree with that. Now, if somebody comes in, again, short segment thrombosis, but we're talking like 80% of the lumen of the main portal vein, then there would be a more frank discussion about, should we be intervening on these patients? And particularly young patients, they don't want to take the risk of just developing chronic PVT without cirrhosis.
Okay, well done. All right, so switching gears a little bit. So we've talked about anticoagulation. We've talked about, in your practice, it sounds like TIPS, but are there any other treatment options that we're not mentioning that either other IR groups are using, or surgical options for these patients?
Yeah, so I'm obviously biased. Surgical options for this group of patients, I think, have much less of a role here, particularly in this day and age. The endovascular techniques have gotten fantastic, and there are some phenomenal people out there doing like incredible work. And so With the exception of transplant surgery, there are still surgeons in the United States and abroad who will say, we don't want to do a portal vein revascularization. We're going to go into liver transplant surgery and we're going to do a SMB jump graft or whatever it is. And they're going to manage it that way. Fine. But other than that, I would say that's one scenario. And I guess the other scenario that I do need to mention is pediatric patients. There are still questions about this patient population and questions about using surgical shunts to manage these patients to maintain brisk intrahepatic flow. Fine. Those two aside, I would say less and less. Now, the other question you ask is really interesting because there's the standard portal vein recanalization techniques, which, I'm happy to get into anytime. There's what we normally do, or lysis and thrombectomy and things like that. There are case-specific scenarios. So, for example, if somebody comes to us post-transplant immediately and they have portal vein thrombosis and you clean them out and what you realize is they have a portal vein anastomotic stricture, then I would either angioplasty or stent that patient. They don't need a TIPS, because you have like a source. So treat the underlying etiology. But in the more broader scheme, which is I think where you were heading, there in Europe, I believe Alban's group, and they've published around this, they make the argument that some of these chronic patients who have chronic portal vein thrombosis without cirrhosis, there are questions about the long-term effects of a shunt on the liver. This is borne out from the pediatric literature. It has not been validated in adults yet, but it is a legitimate question of and that's something we're going to have to figure out. And so there are groups out there that they'll recanalize, they'll open the portal vein, and they'll either stent the portal vein or not leave TIPS for outflow. So you kind of have to mention that in the conversation. Our standard approach here at BI is we do, for the most part, believe in TIPS outflow for these. So I'll kind of put both answers out there. The other thing that I also say is something to consider are alternative shunt strategies. And particularly for patients who maybe have chronic thrombosis and are now finally presenting 5, 8, 10 years later with some types of symptoms related to their thrombosis, whether it be bleeding, whether it be portal cholangiopathy, abdominal pain, bloating, whatever it is. Those patients are not always A, the easiest, or B, the best candidates for a TIPS. Bile duct strictures happen in these patients. Even if you don't cross a bile duct, now you're putting a TIPS right next to the CBD and dilating it that's been dilated, and you may stricture it down and just create this whole secondary set of problems. So in these patients, what I typically will explore are there alternative routes to shunt them. So there's, I know there's some case reports out there. Kei Yamada published on this a couple of years ago of endovascular use of splenorenal shunts. And so I've done that. Sometimes if you're going to decompress, that's one route to do it. There are percutaneous mesocable shunts is another route you can use. We've shunted to coronary veins. I've shunted to IMVs from the renal vein, like a renal to IMV or renal to gonadal. And so there are alternative routes to get the job done. The key is treatment planning around this, because what you also need to be really cautious of is that the longer they're occluded, the more complicated their drainage pathways become. And so you want to make sure that if you're going to be shunting something, you're actually shunting what's going to decompress the area that needs decompressed.
Got it.
And so we have some tricks that we do in practice that I think have helped us and helped me get through these cases, but that's the one kind of thing I throw out there.
All right. Before we actually trying to tackle the mesocable shunts, which feels that'd be another 3 podcasts, I do want to talk about your portal vein recan technique, or kind of how you approach these patients, just from a gearhead perspective. Can you run us through what the procedure looks like, both at a high level, and then we'll kind of drill down on some of the details?
We usually, patients prep, patients worked up, we'll skip all of that. Obviously you want a good team on board. So, we admit them to hepatology after so that, we're watching for any issues that come up. I like to get the neck prepped for all of them. If I'm doing anything crazy or an alternative shunt strategy, which we'll skip over right now technique-wise, I do also tell our technologists to prep the groin, to have an arterial prep. But otherwise, I do a neck prep and I do a full abdomen prep so that the liver is prepped and the spleen is prepped. And then obviously I like a curved ultrasound probe and a linear ultrasound probe. So what we usually do, so I get the neck prep, I get the side prep, I get both sides prepped, and the whole abdomen. If they need drained, we drain them. Standard paracentesis technique. In general, if I'm planning, and I think the best way to start is actually let's just say that this patient is occlusive thrombosis.
Yeah.
Involving everything. And so your access points, getting access to the portal vein is probably your most challenging part. I'll have my fellow. I'm lucky we've got great fellows. So I get neck access, the fellow get neck access, get the wire down, standard 10 French sheath, select out your right hepatic vein. Then simultaneously, I'll work from the spleen. I use a 21 gauge needle, standard 21 Cook or 21 Chiba needle, under ultrasound, stick the splenic vein, I use a double angle GT glide. I actually think it's easier to get in there than a nitinol wire. The nitinol wire sometimes can shear the vein, whereas the double angle GT glide just kind of sails down. And so that's what I prefer.
That's a good tip.
I get that wire in. Once that's in, I am super paranoid about a splenic bleed. And so what I actually do is use an 014 crossing catheter over the double angle GT to make sure I'm vascular. So I put it in, small puff so I don't blob anything out, make sure I'm vascular. Most of the time you are, but the splenic veins are soft, and so you can be perivascular very, very easily, and that's happened. If that happens, I leave it in, get a new access point, 21 gauge needle, and repeat the whole thing again. And, on my way out, I'll gel foam that 014 catheter track. Once I'm confirmed that I'm in the splenic vein, I'll upsize that to an AccuStick sheath, get the AccuStick sheath as close to the occlusion as I can, exchange out for a standard, I like a 7 French sheath in the spleen. And the reason is I find it's easier to close a 7 sheath than a 6 sheath. And so I've gone that route. And I put a straight flush catheter into the main portal vein, and I do a long injection, a long power injection of like a 5 for 25 to really just opacify everything that I can. Now, at that point, my go-to, which I would say probably 90% of the time will get most people where they need to go, I use a Compi catheter and an angled glide wire, or a Compi catheter and a Roadrunner wire. And I try to cross the native portal vein and get into the right portal vein, assuming I'm planning for a right-to-right TIPS creation. Now, once I'm in the right portal vein, I'll obviously puff and confirm, because it's really easy to get into weird stuff, especially when they're either chronically occluded or completely occluded. Once I'm confirmed, I will place an Amplatz wire, and I dilate the main portal vein first before doing anything. And I usually will use a long 8 balloon to do that.
So like an 8-8.
Yeah. And the reason for that, and this is where there is some difference between your acute and your chronics. And so in this case, let's kind of just say we're dealing with a chronic patient, a chronic PVT patient. I found that dilating the portal vein on the front end helps your stent land easier when you place it, versus I've had scenarios where you don't dilate it and you try to deploy the stent, and it just kind of either deploys funny or it sinks down way lower than you thought, which can be problematic for your transplant patients. So once I've dilated there, I'll either leave the balloon up is one way to do it, and you can use that as a target, or you can place a snare if you want, like a 30 millimeter snare. And then on the neck side of it, we'll use a standard Roche kit. I use a Roche Sheeta TIPS kit into the sheath, into the right hepatic vein, and I puncture into the balloon or into the snare, aiming for that right hepatic vein to right portal vein TIPS. At this point, for a chronic thrombosis, for a patient with cirrhosis, you're really talking, a 20-minute procedure. You've got your access, you're through and through at this point. Dilate the tract, dilate again your area of occlusion, and we would at this point drop the tip shut, kind of with the normal standard fashion. Some things to keep in mind, depending on the surgical center you're at and depending on your surgeon's comfort, if they are a transplant candidate, and particularly if you're just getting started in this space, have a conversation with your surgeon beforehand. Don't let them find out after the fact that, oh, by the way, I extended this tips down. And then they're like, well, what did you do? I'm not going to transplant this patient. In this day and age, it happens less often, but it does happen. And so in general, what they like is you want to give them a centimeter up top and you want to give them a couple centimeters away from the SMV in the pancreatic head. So it makes it easy for them to do their anastomosis. So those are kind of like my standard approach to the chronic thrombosis patient on a patient with cirrhosis. Once the tips is dropped, I dilate the main portal vein in the entirety of the tips with a 10. And then oftentimes I'll also dilate the main portal vein to 12. These can be quite stenotic, and so they do need high pressure. Sometimes it'll take some prolonged dilation to kind of work it out. And for the most part, this will do the trick on getting you where you need to be and keeping the patient safe from getting the procedure done standpoint. Now, the point that I always tell people out of all of this, actually the most risky part is your splenic access. And it's not even the access, it's the closure. So there are multiple ways to close the splenic access tract, multiple good ways that are well published out there, utilizing coils, utilizing glue. We use gel foam pledgets and it works well. And I would say find a way that works for you, get good at it, and kind of stick to it and just have an exit strategy if you're going to be doing this type of work so that you can close it and you don't get a call like an hour later of like, hey, the patient's hypotensive. We think they're bleeding from their spleen or liver or whatever access site you puncture, whether it's hepatic or splenic. For us, what I usually do is I roll gel foam pledgets and I cut the sheath. I clamp the sheath at the skin, I should say.
Okay.
I clamp the sheath at the skin so it stops bleeding and kind of pull back right to my entrance site.
Got it.
I cut little strips of gel foam and roll them up so that they can fit into the sheath itself. And then for a pusher, I used the sheath dilator.
Okay.
I cut the tip and put a back end of an 80 ampelatz wire in it to give it some stiffness, and then just use a flow switch to clamp it shut. And I load up the entirety of the sheath with gel foam pledgets. Then I unclamp the sheath and I'll use the pusher to push the gel foam to the tip of the sheath until I see my wire on the fluoroscopy screen, like kind of like right at the rib cage. And then I unsheath the gel foam like a filter.
Okay.
Yeah, and the whole thing takes about 5-10 minutes, and then you can look with an ultrasound right after and you can see a column of gas from the gel foam.
Yeah.
Yeah, and then the flip side of it that I do think is worth talking about if we have a minute here that is important, let's say you do this, let's say you still get, either the anesthesiologist is, hey, we're worried, they're getting hypotensive, or you look at it and you're like, well, it doesn't look like any gel foams in the tract, what did I do? Or they've got like a hematoma. Don't panic. Like there are ways around this that we can figure out. And so the nice thing about having the groin prep if you need to is you can actually just get arterial access and do a splenic arteriogram. And if you identify a bleed, you just treat it. But oftentimes it's the capsule that's bleeding. And so easier said than done. But the two things that I've found work pretty well is because you already have transjugular access now through the tips, you can put your catheter into the tract. And if you do like a light injection, you'll actually find the exact spot that you were supposed to gel foam or pledge it or whatever. And you can, and this has happened to me a couple of years ago, and you see the contrast floating out, and I'll like literally wedge a microcatheter in there and either glue it shut or coil it shut. Works fine. The other thing that I have done that also works, and I've done this for a liver access tract that was bleeding after, you put the ultrasound on. With color, you can actually see the exact site that's bleeding. And you can just stick a 21 gauge needle in it, and usually you'll find right at the color spot that's bleeding. And I've injected either glue or thrombin, and it works pretty well. But I would say the biggest pointer is have an exit strategy and a backup.
Okay. Good tips. My question, and I know that we're coming to the hour, but I had to get into it. So say you lay down your tips, and like how often are you using adjunct techniques like suction thrombectomy, or maybe if lysis is in your practice, how often are adjunct techniques needed to clear out that clot burden?
Often. So what I just went over, I would say, and this is where you were saying like this is just all getting meshed together now, right?
Yeah.
That was like a classic case of a chronic portal vein thrombosis in a patient with cirrhosis. For those patients, like say you're doing this for a pre-transplant patient, very rarely would I do adjunct techniques. Now, if we were talking about a patient with acute occlusive thrombus that was either had cirrhosis or did not have cirrhosis, almost all of those patients will get some adjunct technique. If I'm doing a single session where I'm trying to just get it all done in once, and most of the time for me, that means they only have occlusive thrombus in the main portal vein and the SMV. And like when I say main portal vein, I mean kind of like distal main portal vein and maybe a long segment of the SMV. I will may or may not get my splenic access, get my standard TIPS access, and get the wire across the occlusion down the SMV, stabilize it, put an Amplatz wire in. And what I'll actually do is I place a 16 French gore dry seal sheath directly into the portal access tract, into the main portal vein. I try to get a safety wire down. So now I have 2 wires down the SMV and kind of pull the 16 out, put it back over 1 wire. So now I've got like 1 wire kind of sticking out in the neck, but then I have the other wire across my occlusion, 16 French sheaths so that like we've got nice stable portal venous access. And then I use a 16 French thrombectomy catheter, suction thrombectomy catheter to try to clean out the acute thrombus. My endpoint that I'm looking for is a clean vessels, but good inflow. If it looks great because I'm like power injecting contrast and filling up all the vessels, that's a great image, but that probably tells me that we're going to clot again. Like that flow is not going to support the tips.
Sure.
If I can't get there that way, or if for some reason I'm worried, like if I look at the pictures by pre-op CT and I'm like, hey, there's just a ton of thrombosis here involving like all the branch vessels of the liver, main portal vein, SMV, and its branch tributaries. In that case, what I actually do is I would get neck access, transjugular access, like your standard tips, and I would lyse them overnight and then bring them back. And on day 2, if I need to do adjunctive maneuvers, use aspiration thrombectomy or angiojet or whatever, and then leave the tips on the way out.
Okay. All right. Very nice. So let me see. I'll try and wrap it up here, although I do have some more stuff. Okay. I wanted to talk briefly. You had mentioned in an email that we were sending back and forth, you and your group's preliminary data that you guys had presented at Nashville for 2025 on this subject. And I thought I'd just take a minute to go over the data point that you guys had already presented and I think submitted for publication.
Yeah. So right now we're submitted for publication. There's a couple like interesting pieces that have come out of this. Number one, these patients have just come out of the woodwork. Like we have this graph on there and it's like, flat, 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 flat. And then like 5 months into the clinic, it's just like skyrocketed of where they're coming from. And it's actually a lot of patients without cirrhosis who are showing up. And now I would say that's like the first piece that we noticed immediately was like a lot of these patients were just showing up, and we don't do a patient quality of life survey for this. It's an area that needs to be done that we just have not had the bandwidth to do yet. But these patients anecdotally and subjectively were just coming out of the woodwork so frustrated by being bounced around the system of, we don't know where to go, but everybody just keeps ordering me a CT scan and I don't know what to do with this. So that's the first thing we saw is there was this huge trend in that. There was a huge trend in referrals, both internally and externally. So probably once a month now, we get a patient coming in from out of state or out of country that has just found us on the website and we're like, I have this thing. A doctor told me I had it. I have no idea what to do with it. Can you just help me? I've had pain since I got this diagnosis. And so that's the other thing is we're seeing the network expand or the expansion of our referral base drastically increased, as well as the provider variability. It's no longer just transplant surgeons and hematologists or hepatologists that are sending these patients to us. The other two pieces that, and I think these are like kind of the highlights so that we don't need to get into the boring stuff, that is about 40% of these patients show up and get a change in management.
Wow.
Upon leaving the clinic. And I think it was something like 30% of them have a change in their disease progression at first and second follow-up, meaning that they're going from either progressive or stable disease to resolve or resolving disease.
So in terms of like the change of management, and I'm asking you to drill down on it, but not too specifically, are these patients who are basically getting funneled to you for recan, or?
They're patients, not all of them. Some of them, it could be something as simple as, hey, they never actually had a full hematologic workup, and it turns out they've got this other disorder that needs treated to prevent the long-term complications of rethrombosis. And then there's another group of patients that, they'll be like, hey, this patient needs to be recanned. And they've been told, no. And like we do it. And in fact, we just saw somebody from out of state that was he saw 5 or 6 people. I think he was from the South and just was looking for like a place to go. Then we ended up recanning him and he got his hematologic workup and like, he's as happy as can be. And it's mainly because of that. It's just like a place to go.
That's awesome. Okay. I think that's a good place to put a pin in it. But Vijay, I will just leave it like open mic. Is there anything that I didn't ask about that you wish I had talked about or something left unsaid?
No, I appreciate you having me on. I would say the one thing that I would throw out there is it a great space to work in, and it's also a space that like anybody can get involved. You know what I mean? Like these things are like a lot of what we do. Sometimes it sounds complex, sometimes it doesn't, but like these are all skills that all IRs have, and just have like a method in which you're going to do it and go for it.
That's awesome. Well, that's why one of the reasons I wanted to have you on the show. I was hoping that, people out there who want to get in the space, which I agree, I think it can be intimidating, and not just from a technical standpoint, but I think what a lot of us struggle with is the recan the right decision for the patient. And so that's why I was super interested in having you on from BackTable. We appreciate it. Vijay, thanks for coming on.
Talk to you soon.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Don,
and Aaron Fritz. Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.